Hello, and welcome to Triage Cancer's webinar, Getting the Sleep You Need. My name is Sarah Tarani, and I am the Program Coordinator for Triage Cancer. I will be moderating today's webinar. Before we dive into today's topic, I just need to go over some housekeeping. All callers will be muted for the duration of the webinar. If you have any questions or technical problems, please type them in the chat box to the side of your screen. This webinar is being recorded and will be available for viewing by the end of the week on our website, triagecancer.org. After today's session, you will receive an email with a link to the evaluation. We would appreciate it if you would take a few moments to provide your feedback. Okay, as part of the accreditation process for healthcare professionals, we have to read the following disclaimers and disclosures to you. This presentation is intended to provide general information on the topics presented. It is provided with the understanding that the author is not engaged in rendering any legal, medical, professional services. Although this content was reviewed by professionals, it should not be used as a substitute for professional services. The planners and presenters for this program have not disclosed any pertinent financial relationships or conflicts of interest. While this educational program has received commercial support from any previous listed sponsors, the content of this program has no relation to the commercial interests of the organization's products or services. I'm pleased to let you know that Triage Cancer is an accredited provider of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. Therefore, nurses participating in the live webinar and the meeting, the following requirements will be eligible for 1 contact hour. In order to receive contact hours, you must have registered online for today's session. People who are listening in on someone else's computer are not going to be eligible for credit. You also must attend the entire webinar. No partial credit will be awarded. And anyone watching a recording of this webinar in the future will also not be eligible for credit. Within 1 week of this webinar, complete the evaluation and post-test. You must receive a passing grade on the post-test to be eligible for contact hours. And again, you will receive an email following this webinar, which will have the link to the evaluation and then the post-test. Please note that on the evaluation, it asks for your name and email address, and you have to include these so that we can certify that you completed the evaluation and that you attended the entire webinar. This email is the address that we will use to mail the certificates as well, and I'll be sending those out to you within 4 to 6 weeks. For other types of healthcare professionals, we are more than happy to provide a general certificate of attendance. Just make sure you indicate that on the evaluation. If you have any questions or experience any problems, email us at info@triagecancer.org. Now, in order to receive those contact hours per day, we have to be able to verify your participation. So if you are calling in from a phone, you must also log in from a computer or use the smartphone GoToWebinar app and input the audio PIN. You can find the audio PIN in the control panel to the side of your screen and under the audio tab. If you are already on a phone, simply press the pound sign and the number you see on your panel, and then pound again, and then you will be logged in completely. Now, for those of you who aren't aware, Triage Cancer is a national nonprofit organization that provides education on the legal and practical issues that may impact individuals diagnosed with cancer and their caregivers. We provide this in a few different ways. First of all, we host a speakers bureau of experts in all types of cancer survivorship issues available to organizations putting on an educational event. You can read our speaker bios and request a speaker on our website. We also participate in events all over the country, and some of those events we host and some are hosted by our partners in the cancer community. See where we are going and take a look at the events on our website at the events calendar. So every year we host the Triage Cancer Conferences. This is a day-long event that covers a variety of cancer survivorship topics. We welcome patients, survivors, caregivers, advocates, and healthcare professionals to this free event. This year we'll be in Chicago, Chapel Hill, North Carolina, and Houston, Texas. Registration and applications for travel grants are now open. As you know, we host a monthly webinar series open to anyone in the cancer community. The next one will be on April 29th, entitled Explaining Neuropathy. And recordings of past webinars are also available on our website. In addition to our events, we offer a number of educational materials and resources online. Our quick guides are designed to be a snapshot of a particular topic. They cover areas such as health insurance, employment, clinical trials, financial topics, estate planning, and legal assistance, and more. We also have checklists and other documents designed to help with the legal and practical pieces of cancer survivorship. All of these documents can be downloaded for free on our website, or you may order hard copies of these materials on our website at triagecancer.org/material requests. And we will mail those out to you as long as we have those hard copies available. And because we recognize that everyone learns in different ways, we also provide educational animated videos on cancer survivorship topics. We just released one on dealing with the side effects at work, with key information that you need to know about reasonable accommodations to help you work through treatment and to get back to work. We also have videos on health insurance basics and picking a health insurance plan. More are being added constantly. We are also very excited to announce that thanks to the support of the California Dialogue on Cancer and Genentech, we now have several resources available in Spanish, including most of our quick guides and all of our animated videos. Again, these quick guides can be downloaded for free on our website. We also have compiled the contact information for some of the most frequently used state-specific agencies and resources on our website. And because where you live can greatly impact what protections you have access to, we have charts of state laws on employment, disability, health insurance, and other cancer-related issues. Cancerfinances.org is a site that we host in partnership with the SAM Fund that provides practical information on topics that can impact your finances. This website is designed to guide users to the information that is most relevant to their situation. We currently have modules on health insurance, disability insurance, education rights, and financial assistance resources. We're excited to announce that earlier this month we released the module on estate planning. More topics will be added soon. And finally, our educational blog not only provides great information about cancer survivorship topics, but because things are constantly changing in the cancer community, this is how we share late-breaking news. Our monthly e-newsletter is where we announce all of our upcoming events. Okay, with no further ado, let me introduce today's speaker, Eric Zhou. Eric is on faculty Eric is on faculty in the Division of Sleep Medicine at Harvard Medical School and is an attending psychologist at Boston Children's Hospital and the Dana-Farber Cancer Institute. He is here today to talk to us about sleep and the impact it can have on our health. So with that, I will turn it over to Dr. Zhou.
Thank you, Sarah. It is an absolute privilege to be able to have the opportunity to talk to folks today about a subject that is absolutely critical in terms of your recovery post-cancer and during the treatment process itself. Now, in terms of what we get to do, this is fortunately a short block of time, and unfortunately only a surface level discussion of so many important things related to your sleep, and I would be happy to continue the conversation with folks offline after the webinar has ended today. I have a couple of key goals. First is I hopefully do not have to work too hard to convince you that sleep really matters, particularly for the cancer population. Help you recognize when sleep exceeds some threshold that is important and relevant for you to consider further as something that warrants further medical attention. And at the end, think about ways that you can implement some behavioral and lifestyle changes to help you improve your sleep and overall health at the same time. And ultimately, the idea is to have you think about sleep actively as opposed to it being something that just occurs every night. And I want it to be something that you are aware of in terms of how we can make it better. In terms of sleep itself, I want folks to think, how many hours of sleep do you feel like you should be getting each night? Now, unfortunately, this is not an opportunity where we get to interact back and forth, but I want you to pick a number. If you can think in your mind about a number, what that might be, and I'm going to give you a second to think about that. So if you have a number in mind already, what I would say is typically what I hear when I am speaking with patients is that that answer is somewhere around 8. 8 happens to be the number I hear a lot. And the reason for that is simply because we get a lot of information from the media that tells us that adults need somewhere between 7 and 9, and often the number is 8. Now that works great for a news bite, but unfortunately it's not the most accurate information when it comes to how we are. We are all very much individuals. We have very different characteristics about our health, including our sleep. As you can see from the National Sleep Foundation, for adults and older adults, the range of sleep can be anywhere from 5 to 10 hours as being something that could well be normal. And somebody who sleeps 6 hours a night, for example, does not mean that they are not sleeping sufficiently, whereas somebody who sleeps 10 hours a night does not mean that they are sleeping too much. This is a conversation to have further with a sleep provider. However, this is to say that 8 is not some magic number that every adult needs to achieve. Now, we're going to focus a lot of our attention today on insomnia disorder, and the reason for that is because it is the most common sleep issue for patients after cancer, and it is also one that is very sorely misunderstood and poorly treated in a lot of oncology settings. The reason that I have the diagnostic criteria here is not because this is going to be a test item, but because it's important to appreciate just how low the bar is to be diagnosed. Briefly, if we look at the diagnostic criteria, the summary that's important is to note that at least 3 nights a week, folks must struggle with falling asleep or staying asleep, and that this has to occur for 3 months or more. And the threshold we typically think about is 30 minutes per night, which means if you are somebody or somebody that you know takes more than 30 minutes to fall asleep or is awake for more than 30 minutes at night. And this is a combined number, meaning that if you take 25 minutes to fall asleep and then 20 minutes you are awake in the middle of the night for a total of 45 minutes, you have exceeded that threshold. That bar is the only threshold that you need to meet in order to meet the diagnostic criteria in terms of how your sleep is. Now, the rest of the criteria are typically seen in most sleep disorder diagnoses, in that it has to affect your day, it doesn't occur as a result of other medical issues, for example. But that threshold, that bar for how disrupted your sleep is to have insomnia, is much lower than many of my patients assume it is. And the reason that I want us to understand that as a baseline is because it is so much more common and impactful than we think. Now, folks up in Canada did a really great study looking at how insomnia develops for patients with cancer. What they did was they looked at a group of folks before any surgical intervention for their cancer, and that was what they considered to be baseline, and they followed them for a year and a half post that treatment. And what they saw over time, and at the bottom is the months. So 0 means before any treatment, 2 is 2 months post-treatment, all the way up to 18 months. The prevalence that they saw of insomnia in this group ranged from 25 to 36%, and as you see, is a natural trend towards a decline, which makes sense that folks not in the very stressful throes of cancer stage at baseline, that they seem to be better. But what's important is you're talking about folks who a year and a half out, that about 1 in every 4 cancer patients has insomnia. So this is absolutely something that affects a great number of survivors out there. At the same time, it's important to understand what's not insomnia because it is often conflated with other sleep disorders. I have a list of a range of different sleep disorders which are not insomnia. They could be occurring along with insomnia, but they do not, absolutely do not get treated in the same way that insomnia is treated. For example, common ones would be something like sleep apnea, which is something that may cause insomnia, but is not actually only insomnia in and of itself. Now, sleep overall matters, and I think that this is something that we all appreciate from having a bad night or two of sleep, which is to say we think that the next day that we feel tired, that we may not be able to concentrate as well, we may be a little bit more grumpy than usual. But more than just that, there is really compelling evidence to suggest that both physical and psychological health outcomes are impacted by people who do not sleep well chronically. What I do want to do is, instead of going into all of the research showing that sleep impacts cardiovascular health, weight gain, depression, alcohol use, all of this, I want to focus on something that is particularly salient for the cancer population. Folks out at Stanford did a really great study where what they looked at was a group of women with advanced stage breast cancer. They measured their sleep using a tigraphy. And a tigraphy device is a specialized medical device that tracks when somebody is asleep or awake. Typically, what we think of is 85% as a threshold for good sleep efficiency. Sleep efficiency is a ratio of the amount of time somebody spends sleeping divided by the amount of time that they spend in bed. The higher, the better. The higher means that you are going to bed, falling asleep, and staying asleep. They divided this group into two separate samples: a sleep efficiency of 85% above, which is what we typically consider to be good sleep efficiency, is in the blue, and folks with a sleep efficiency of below 85%, which we think of as bad and we would want to intervene, are the women that are tracked with the red graph here. These are survival curves, which looks at over time for these women with advanced stage breast cancer, how many of them survived. And what you hopefully can see here without having a statistics background necessarily is that blue looks a heck of a lot better than red. In that study, they said that their data suggest an improvement in sleep efficiency of 10% among those women in that red category, which is that they had a sleep efficiency below 85%, that could potentially lead to a 32% increase in survival, which to me is absolutely astronomical in terms of thinking about how much sleep matters. Because I guarantee you that if there is a pharmaceutical company out there that found a drug that increased survival among women with advanced stage breast cancer by 32%, this company would be absolutely on the cover of Time magazine. And yet we're really not talking about sleep in the same way. Now, I say this because we know that sleep is something that people laugh about. This is actually a cookie chain that's in the Northeast, if you're familiar with insomnia cookies. And I hope that if we go back to the last slide, the message should be that insomnia is actually not a trivial matter. This is not a joke. And I think about this for our patients here to say, you wouldn't be very funny if we called the store cancer cookies. It would be appalling as a name. And yet at the same time, the idea of insomnia as being something that just bothers you, it's almost like having an itch, is absolutely not the case. That this is something that absolutely gets under our skin and affects our physical and mental health. Now, once you are in clinical practice, if we think about what typically happens, you're a patient, you go to your oncologist, you go to your primary care, and you say, well, I have all of these sleep symptoms. I went to this webinar and I feel as though I have insomnia. What do? Do we go into pharmacologic treatment? Do we talk about some sort of a behavioral approach? What typically happens? And we know from good information that in the context of cancer, that medication is probably the most common solution, that about 1 in every 5 cancer survivors has used this medication recently. And importantly, what we see is that these are not people who use them once a week, once a month. That typically what happens in the context of cancer is hypnotic medications for sleep are used regularly, which means multiple times a week, and chronically, which means that these are individuals who are taking them for months and months and months, not as a let's use this as a solution to get us through the next 2 weeks because I'm having surgery, for example. Now, there are concerns related to the use of pharmacology when it comes to sleep. We know from a good deal of epidemiological data that many of the medications that are used to initiate or help initiate or maintain sleep have side effects associated with them. We, of course, recognize that when we take a medication that they all come with some sort of a side effect profile. Unfortunately, for many of these medications, the side effect profile is fairly serious. And in fact, we see that there is an increased risk of mortality for the use of hypnotic and anxiolytic medications, which is, of course, something that we want to avoid. Now, all of this is not to say that there is no role for medications to assist with sleep. It's to say that it is absolutely used excessively when there are alternatives in mind, and we'll talk about that in a moment. In terms of over-the-counter drugs, something that folks I work with call vitamin M is melatonin. It's something that I see much more often now than I did 10 years ago in my practice, and I commonly hear providers and patients say, you know what, it's over the counter, it has to be safe. I've been told melatonin can help with sleep. The truth of the matter is, though, that melatonin is not an FDA-regulated product. That means there is no formal oversight over what is produced and packaged. And what a group of folks did was, well, they took melatonin, 31 supplements off of the shelf, and they said, you know what, let's see what in the heck is actually in this melatonin. And what they saw was that there was incredible variability within the brand and between different samples of what was contained in each tab. So they saw a great variance in terms of how much melatonin was in the actual tablet, and more importantly, that on about 20% of these samples, they found other things that presumably you should know about. For example, on 8 out of 30 samples, that there was serotonin in the actual sample itself, which makes sense given that serotonin is a precursor chemically to melatonin. But of course, for folks who are taking, say, an antidepressant, which is an SSRI, they would want to know if there is serotonin that they are ingesting. Now, if we're thinking, okay, if it's not this medication business, if it's not over the counter, well, what kind of things should we be thinking about? And the American College of Physicians in 2016 came out with a very clear statement. What the ACP had stated at the time was that all adult patients, this is not some, this is not if you failed medication, this is all patients should be receiving CBTI, or cognitive behavioral therapy for insomnia, as the first, the initial. This is what you should be doing. Now, it's important that we get into what that actually looks like first, but before we get to that business, I want folks to have an appreciation for how insomnia develops, because that serves as the underlying piece of knowledge that helps you guide what treatment looks like. So if we take that step back and think about what actually causes insomnia, this graph I want folks to look at. If you look at the bottom axis going across where it says baseline, acute, early, and chronic, that refers to your insomnia. So baseline, you have no insomnia. Acute is when you have just started insomnia. Early is the first couple of months of having insomnia, and chronic is 3, 4, 5, 6+ months of insomnia. And if we pick an arbitrary level here, let's just say 50 as the sleep disturbance intensity, how bad your sleep is. And let's just say that for folks, if you're above this arbitrary number of 50, that you have insomnia. If you're below, you kind of have some bad sleep, but you don't have insomnia. That's what we'll assume first. So at baseline, what you see here are the blue characteristics that I'm looking at, which are your predisposing factors. These are the things that you bring to the table that make you more likely to develop insomnia. So for example, if you are a woman, if you are older, if you have a family history of insomnia, if you have a psychiatric history. These are all things that make you more likely to develop insomnia, but as you see, over time here, this does not change. Because what you bring to the table, whether or not you have insomnia, is what you bring to the table. You are female, whether or not you have insomnia, for example. What's important to then note is the second P, which are the precipitating factors in green. These are the things that kick you over that arbitrary threshold, that kick you into having that kick you into having insomnia. This could be finding out that you have cancer. This could be being in the hospital for multiple days. This could be you having a surgery. This could be pain post-surgery. This could be negative life events, like, for example, if you're going through a divorce. It could even be positive life events, like having a child or having family move into your home with you. It's not necessarily a bad thing for a precipitating event. It just means that something occurs that makes your sleep disrupted. What you will see over time is the precipitating factors, they reduce in intensity. For example, if you received the news that you were diagnosed with cancer yesterday, I absolutely can appreciate and understand why you won't sleep today. However, if we fast forward 2-3 years later, well, understandably, you are still absolutely affected knowing you had cancer, but that emotional impact of finding out yesterday you had cancer is absolutely not disrupting your sleep 2 years later. And that's what we see here, is that the precipitating factor, what caused you to have the insomnia start, reduces over time, such that when you have chronic insomnia, it is often unlikely that your predisposing and your precipitating factors are enough to maintain the insomnia. So then I hope the question is, well, what is maintaining the insomnia? And in this case, these refer to the perpetuating factors. These are the things that we are doing that are wrong, that are targeted by this cognitive behavioral therapy for insomnia. So these are things like sleep effort, excessive time in bed, irregular sleep-wake schedules. All of these are the things that, as you see, become sufficient to make you continue to have insomnia, even though the initial reason why you developed it no longer bothers you. So if we come back to that, what is CBT for insomnia? For folks who hear about therapy, they may imagine you sitting on a couch talking to somebody about your mother, or if you've actually received CBT for another mental health issue like depression or anxiety, for example, what I like to tell everybody is it's actually not like any of that. That's the important thing here, is CBT for insomnia is a very special subset of skills that you learn that is different than what another type of CBT is. And that's something I caution folks about, is they often say, you know what, I have a psychologist I work with, we've done CBT, and I say, well, sure, that's wonderful. I'm glad that this is something you have experience with, but at the same time, I'm not sure that you've done CBT for insomnia, and we're going to talk about what it looks like. Now, CBTI, to give you the nuts and bolts of what the middle, the magic, the look inside that black box, what it is, it's comprised of 5 key components: sleep restriction, stimulus control, sleep hygiene, cognitive issues, and relaxation. And we're going to go through these so that you have a sense of the flavor of what it looks like. I do want to emphasize one thing that you see here, which is sleep hygiene as a component. And sleep hygiene is actually very typically what you will receive when you tell your primary care provider, I have insomnia. It also is often what you see online when you Google, I cannot sleep. Understand here that it is one component and one very, very minor component of what CBT for insomnia is. So if you've worked on your sleep hygiene in the past, it absolutely does not mean that you've done CBTI. Now, I get to talk to you about CBTI-ish. This was actually a photo I took when I was on a recent trip to China. And as you can see, this is really not Starbucks. This is clearly copyright infringement. But this is what we get to do today. I don't get to give you Starbucks coffee. I give you the Starbucks coffee, which is, it kind of looks like it, kind of feels like it, but it's not exactly what the real process is. But it should give you the flavor and give you a sense of what to expect. However, I don't want you going home thinking, okay, I'm going to implement these strategies and have done CBTI. Now, the first step is to collect data about your sleep. Many folks think, well, I have a Fitbit, I have an Apple Watch, I have a whatever device. And what I tell them all is, unfortunately, as of today, all of these devices are essentially not the world's best sleep data collectors. And in fact, what I would argue is I wouldn't even look at them when I have patients who come in with the output. And it's not because these devices aren't well designed, it's because these devices have not yet been validated against a gold standard to demonstrate that they accurately capture when sleep occurs. It's a really complicated process, sleep is, and these devices have yet to figure out how to calculate and give us good information. So, if not these devices, how do you keep the data? The easiest way is, well, pen and paper. It's a sleep diary. The top is simply of this slide here, you see, you put down arrows when you go to bed, shade in when you are sleeping, up arrows when you get up. A W next to that indicates that you were awakened by an alarm clock, a husband, something. S would be spontaneous, and this tracks graphically your pattern of sleep. The bottom sleep log is simply something that you track by putting down the information, like when you fell asleep, how many times you woke up, total time awake at night. This is actually all I ask my patients to complete. It's incredibly primitive in terms of the use of no technology, but the data, if we collect it over about a week to 10 days, is incredibly valuable. In fact, without this, I do not treat my patients, because what we do in CBTI is tailor the treatment to what your actual sleep looks like. So this is the first step. The second thing that we talk about is sleep restriction. And this is one of the heavy hitters of CBTI. Now, if you see here, these are 3 commonly prescribed medications for folks who struggle with sleep: Ambien, Klonopin, and Ativan. Which one of them do you think is the best sleep medication? And this is a bit of a trick question, because the answer is none of them, and I'm going to explain why. The best sleep medication that you can actually take is not a medication at all, but it's actually being deprived of sleep. That every minute we are awake, we are accumulating sleep debt. The more debt we have, the heavier that pressure to sleep feels. We've all experienced this. Like, for example, if you haven't slept for a night because you, let's just say, woke up really early for a flight and you are going to the airport at 4 a.m., your sleep debt is often so heavy that you wind up doing something like falling asleep at the airport or on the airplane, neither of which are places that are really conducive to good sleep. Nobody says, I can't wait to go onto my United flight and squeeze into an economy seat and try to sleep, yet you see people on these 6 a.m. flights falling asleep. It's because they are so sleep deprived. That is something that we actually channel with this program. I'll give you an example of what this looks like. So in this case, a patient comes in and sees me Thursday to Friday. They're going to bed around 9 o'clock at night, but they don't fall asleep until an hour or so later. They need to get up around 6 o'clock for work, but of course, because they have insomnia, they wake up in the middle of the night, and they're frustrated by this. Come Friday, they come home from work. They take a quick nap before dinner because they're so tired. They've struggled all week. They still go to bed at 9 o'clock, hoping to sleep that night. But of course, it's Friday night. They're in bed. They watch Netflix for a while. They don't fall asleep until close to midnight. But because it's Saturday morning, they get to sleep in until 9 or 10 o'clock because it feels really good. And then they repeat this pattern Saturday into Sunday. Of course, what happens Sunday into Monday, they go to bed hoping to fall asleep, and they don't until now midnight because their body has been accustomed to this. They still have to wake up at 6 and they feel miserable, and it's this rinse and repeat cycle week in and week out. by restricting their sleep, what we do is we set a consistent wake time and a prescribed no earlier than bedtime that matches the total amount of sleep that they've gotten previously, essentially then filling in the gaps. Because if we create a constrained period of sleep opportunity, we force sleep to occur in that period. And in this case, the title of the slide reminds us the goal here is always to talk about what works best in the long term in a couple of weeks, as opposed to what this patient wants that short term, which is to sleep in until 9 o'clock on Saturday and Sunday, which feels good short term, but disrupts their sleep in the long term. Now, if we think about what sleep restriction light might look at, it is actually getting up at the same time every single day of the week, whatever time that might be. Because for many folks, what they do is they oversleep when they can on Saturday and Sunday, typically, because they have not gotten enough sleep during the week. But because they oversleep on Saturday and Sunday, it fills the tank too much so that come Sunday night, they are not as sleep deprived, and thus they struggle to fall asleep, and that cycle repeats the subsequent week. The second piece, a second heavy hitter of what we do, is called stimulus control. And stimulus control describes the idea that we use bed for one of two activities, sleep or sex. Now, most folks tend to assume when I say this, I'm telling them not to do things like go on their phones in bed, not to read in bed, or watch TV in bed. And while all of this is true, another really important thing, perhaps for me, even more important, is what this guy is doing, which is for folks who have insomnia, they often, as they're trying to fall asleep, or as they're trying to fall back to sleep in the middle of the night, try to get the circumstances and environment just right. It needs to be dark, it needs to be perfectly cool, they have to lay in a certain direction, and if they just try hard enough, they'll fall to sleep. And in this case, what's really important to understand is that is what I call sleep effort. And sleep effort will always fail you. If you think about that analogy I gave earlier about getting up early for a flight, think about folks, if you have a 6 a.m. flight and you need to wake up at 4 a.m. to get to the airport in time, the night before you're typically really worried about getting to sleep because, well, you want to sleep well so that when you arrive at your vacation destination, you feel rested. So maybe you go to bed at 8 and you lie there and you don't fall asleep until probably 1 a.m. And then you still wake up at 2 a.m. and 3 a.m. and you look at your alarm clock and you're incredibly frustrated. Well, that is sleep effort. It is the push to try to sleep. And that will always fail you because sleep effort increases your hyperarousal. It makes you more anxious, and therefore it makes it harder to sleep at that time. Sleep is a natural physiological process. It will happen if you have not slept for long enough and if this is approximately the right time of day. Those two interact with one another. And I think about it almost like your appetite. I don't think anybody on this call has ever been concerned if they were going to be hungry in time for dinner. You would say, if you're not hungry at dinner, you know what, let's just wait a couple hours and we'll eat. Because you realize that if you just wait a few hours, if you're not hungry, your body will naturally start to get hungry. That's the exact same phenomenon when it comes to sleep. Third, we talk about sleep hygiene. These are the things, like I said earlier, that you look up online that are things that clean up loose ends. Now, in this day and age, I typically don't have patients that have really terrible sleep hygiene because most of them have already gone online and done things like made sure that their bedroom is quiet, made sure it's not bright, tried to use less electronics when they're going to bed, don't eat heavy meals before bed, no caffeine. These are, again, details. Now, does this mean that I don't have any patients that aren't doing terrible things like having a coffee before bed and wondering why they're not falling asleep? No. But it is to say that the vast majority of my patients have already cleaned up their sleep hygiene fairly well. The fourth piece is related to the cognitions that relate to sleep. These are the thoughts that occur in your mind when you are trying to sleep, be it at the beginning or at the end of the night. Folks often have these thoughts. Usually they're more panicked than what I'm describing now, but they could be things like, if I don't sleep well tonight, I don't know how I'm going to be able to work tomorrow. Or this has to stop. My insomnia is going to make it so that my cancer comes back. Or I'm never going to fall asleep with so much that I have to worry about. These often become self-fulfilling prophecies, in that the worry and concern over not sleeping increases your body's inability to sleep because you're so busy worrying about it. And it's very much paradoxical that the more you worry about sleep, the less you can sleep, which makes you worry more about sleep. I think about it as somebody who's trying to hold sand in their hand. The tighter you squeeze the sand, the more of it leaks out and the less of it you can actually hold. And in this case, the tighter you squeeze sleep, the harder it will be for sleep to occur. And so a part of this work is helping people work through these maladaptive cognitions as they relate to sleep. It's also about setting appropriate expectations. If we think about this as the slide that I showed you earlier about the average sleep that people need, let's just say, for example, that there are two people. One person needs 7 hours, one person needs 8. Well, if the person who needs 8 hours is getting, say, 8 hours of sleep, they feel pretty darn good about it. But what if that person thinks that they need 9? Well, they'll be disappointed. If that person who sleeps short, who sleeps 7 hours per night, if they get 8 hours because they're taking naps, they're staying in bed as long as they can, well, they're still not going to be happy because they feel tired throughout the day because they are in bed for too long. So it's about matching the actual sleep you get to what your body needs. And that becomes something that you get to figure out through the sleep restriction phase of this program. And finally, it's a reminder when we think about sleep expectations that sleep absolutely occurs in the context of many, many other pieces. That how you feel in the morning when you wake up is not 100% connected with how you slept last night. And that's often a surprise for many of my patients, that when they really stop to think about it, that there are some days that they sleep wonderfully and they still wake up feeling tired or stressed, and some days in which they sleep terribly and they wake up feeling okay. And it's because, as I said, sleep occurs in the context of so many other things, like your medical issues, like whether or not you got into an argument with your husband or wife last night, whether you have children who are disruptive, whether it's too hot and your AC broke, whether work is stressful, whether you have something to look forward to, like you're going to the Super Bowl tomorrow. These are all things that impact how you feel that have nothing to do with how you sleep. And an example I can give that often people understand is, if you wake up at 6 o'clock for work, you feel a certain way. But let's just say you're waking up at 6 o'clock because you're going on a week-long vacation to an island you've been looking forward to for a month. Somehow 6 o'clock doesn't feel as stressful as it does when you wake up for work. And it, again, has nothing to do with how you slept. And in that case, everything to do with what you have to look forward to or not. And then finally, relaxation exercises. This is a case where there are so many different relaxation exercises that can be pursued. I don't have a specific one I want folks to pursue. However, what I do say is the goal of this is not that you relax to sleep, but that relaxation can help you sleep. Meaning, if you are saying, I'm going to practice meditation tonight at 9:30 because I want to be asleep at 10, you are committing that sin of sleep effort. You are doing an activity intending to sleep. What I tell people is to reframe that if you are meditating at 9:30, it's because you enjoy it. It feels good, and it likely has this benefit of reducing your physical and psychological levels of arousal, which makes it more likely you'll fall asleep when you want to. However, you shouldn't be doing the activity just because you need to sleep, because that again puts pressure back on that sleep. So these are the 5 nuts and bolts components of what CBTI looks like. For those of you that are incredibly diligent, good patients, there are a number of good online resources in terms of texts that you can actually purchase that walk you through exactly what we've talked about in good detail. And there is evidence that people who are really motivated can work their way through this treatment. However, these are also often the patients that when their primary care says, look, Jane, your blood pressure is high, you need to eat healthier and exercise more, that Jane is the person who actually does that absolutely to a T for the next 6 months. If that's not you, there are alternatives to consider. There are some online programs. One of them is Shut Eye right now, which is actually going through some approval processes, so you cannot sign up for it. However, these are programs that I believe can be pursued either in the future, in the coming months, or I believe Sleepio is currently available still for you to register in, and they will do this in a very interactive way, and there's good research data to suggest that these programs can help you with sleep. And finally, you can go to the Society of Behavioral Sleep Medicine's website. They will have a listing of providers by state so that you can look to see if there's somebody who offers this kind of work close to you. And as I said earlier, please be cautious that somebody who does CBT doesn't necessarily do CBT for insomnia. I appreciate the time and the invitation from Sarah, and if there are questions, I'm happy to address any of them for the group.
Fantastic. Thank you, Eric. I actually had a question that occurred to me as I was listening to this. I realized you were presenting on the issue of insomnia, but say you're a person who doesn't have a sleep problem, or gets the appropriate amount and feels good about it, but also has horrible sleep hygiene, does napping in the day, watches a movie for 2 hours every night in bed, but it's not affecting them. Is that still bad, or
That's
does
a
it not
great,
matter?
yeah, it's a great question. And in this case, it's all about perception. So if somebody is going to bed, falling asleep, staying asleep, and waking up feeling rested, I have no compelling reason to encourage this person to not do those things. I would say to them, if let's just say this person would never find their way into my clinic, but if this was a friend, I would suggest, these are all things that may mean that in the future, if something happens, if a precipitating event occurs, that your sleep gets disrupted and you are more easily tipped into insomnia. But if it doesn't bother you, and there are many people who can do all of these things and be just fine, then certainly does not mean that you have to address anything.
Okay, all right, good, because I think that is a lot of people.
Absolutely.
Okay, I think that we are about ready to wrap up. Eric, can you advance the slide because I'm having issues here? Yes,
Absolutely.
okay. So this was our question slide. You could advance beyond that. That would be great. Okay, I just want to go over these contact hour requirements again because this does get confusing for people. In order to receive contact hours for today's webinar, you had to have registered online and you had to attend the entire webinar. You have a week to complete the evaluation and post-test, and you have to receive a passing grade on the post-test to be eligible for contact hours. And you will get an email automatically that has a link to the evaluation, and as you go through the evaluation, then that links to the post-test. And please make sure you include your email address on that evaluation. That is essential for us to verify that you are actually attending the webinar. And for other healthcare professionals, we are happy to provide a general certificate of attendance and just indicate that on the evaluation. And if you have any questions, of course, please email us at info@triagecancer.org. And thank you to everyone, especially Eric. Thank you so much. And this is all we have time for today. And we'll see you again next month. Thank you very much.